So then it is time for Dr. Salman Sharif to talk on percutaneous pedicle screw fixation and interbody fusion.
Thank you, Mehmet. Thank you, WFNS Spine Committee, as always, have been doing a lot of work, and Mehmet has been at the forefront. And it's brilliant to combine with the Bangladesh Spine Society, and it's an honor to be here. I'm sorry, I've had COVID for the last couple of weeks, so my throat might be slightly gone, but it's not that bad. What I'm going to do is talk about percutaneous pedicle screw fixation. The problem that I see with young people who are trying to learn minimally invasive surgery is causing serious issues, not knowing simple tips. And this is what I'm going to be talking about. I'm not going to go into hi-fi surgery of any kind, just show you how exactly it's done and how simple it is. And there are basics. If you follow, then the results are going to be reasonable. So this talk is mainly meant for young spine guys who are trying to start out. So why percutaneous screws? We have already talked about it. You get less pain, you get less infection. The results are adjacent segment diseases less. There are many issues that you can avoid by doing a percutaneous pedicle screw fixation. There are multiple systems on the market, all kinds of them. All of them work the same way, and there are minor differences. Principle remains the same in all of them. So there are procedure benefits, minimally invasive posterior fixation with cannulated screws, dissection and soft tissue retraction not required for screw placement. Muscle is dilated, not cut. And once you have that, the blood supply remains intact. The chance of infection remains low. The chance of adjacent segment disease is less. And your tension band remains intact, basically in making sure that you don't get adjacent segment disease, or the risk is much less compared to open surgery. The important thing to understand is when you're starting out, you don't know how much of fluoro you're taking in. So when you're using image intensifier, you need to be careful with your hand. If you look at it, average hand exposure for a single shot is 58 milligram per minute, and 10 to 12 times greater over other musculoskeletal sites. And if you look at it, 4 to 5 minutes fluoro time, image time, you can have maybe 200 cases per year. Annual recommended hand dose crosses by 50 grams straight away. So we have to be very careful what we're doing with our hand. Your hand should not be inside in the area where you're imaging. So it's especially for young people. It's important to understand you've got all this cluster. You need to look at the X-ray source, and the source itself, this is the area which you should be careful about. And if you're going to have it on AP imaging, you have to have it down to make sure it doesn't cause problems to you directly. Also, you cannot have all this hand in there. You need to have some kind of instrument with which you catch the instrument to make sure that all this cluster doesn't get on top of your hand. So it's Compton scatter, which is very, very, very important, that once that scatter comes in, you can have serious problems in the long run with your hands, with your joints, and you don't want to be having that. Fluoroscopy, it's largely performed via AP imaging. The important thing to understand is if you're doing a TLIF, you can go up to 4 to 4.5 centimeter, depending on how obese the patient is. Pedicle screws 3 to 3.5 centimeter. PLIF, we used to start with 2 to 2.5 centimeter. And you can see your imaging has to be perfect. Your alignment has to be right. Your joints, you should be able to see appropriately on both sides. The spinous process should be in alignment as well. This area of entry into the pedicle of about 2 centimeters is very important. We'll talk about it. You need to have a biplanar fluoro, a true AP, and true lateral. What is true AP? Is if you draw a line, both the lines should be perpendicular to each other. And then if you draw a line in the middle through the spinous process, it should be smack in the middle. The two auli pedicles should be very clearly seen. Same thing happens with true lateral. The box has to be completely in alignment. And top of it, you should be able to see the two lines of the pedicle the way you want to see it. So true AP and true lateral is very important to start out. If you don't have it, either adjust your table or adjust your fluoro, image intensifier. Something needs doing to make sure that you see all this correctly to have the results right. For S1 pedicle, there's a Ferguson view in which you have got slight tilt of the C-arm with the head rotated cephalled 10 to 15 degrees. And then you'll be able to see the lumbar pedicle very clearly. If you go further to 25 to 30 degrees where our S1 pedicle angle is, then you should be able to see that as well. And why? Because the S1 pedicle itself is like a hook that goes all around like that. So it's like a fish hook that we see. So you can see on both sides that you can see this fish hook. So that's the pedicle that you should be clearly able to see on S1. So pedicle identified on AP, as we saw. Starting point on the skin is lateral to the pedicle by 1 to 2 centimeters, depending on how obese the patient is. The intersection of the facet and the transverse process provide a good starting point. So if you've got the facet and the transverse process, that's where you start out. And it helps avoid going into the canal and following the natural inclination into the pedicle. So it depends on if you're doing T-lift, you're going to be going way far out. Whereas if you're going to be just putting in MIS screws, then you'd be coming somewhere here. After making a 1.5 centimeter skin incision, the needle is advanced to the facet TP intersection. And what you do is you've got your Jamshidi needle sitting like that, just at the junction. The AP fluoroscopy, again, is the main key for pedicle navigation. The critical aspect relates to staying lateral to the medial wall. AP fluoro is the only view that gives you the perfect information about if medial or lateral to it. So in order to avoid entering into the canal. The sequence of Jamshidi needle is very important. What you do is you dock at the entry point, as we talked about, the transverse process and the joint itself lateral to it. And you should be holding it with an instrument, not with your own hand, so that it doesn't, your hand doesn't come in the way. Your radiation doesn't bother you. Then once you enter, you're up to 2 centimeter depth, then you're still halfway down. You haven't crossed the medial edge. That's very important. And both needles are at the same depth. So once you have both needles entered over there, then your next thing is going to be to advance it through the pedicle to the dorsal aspect of the vertebral body. The important thing is the intersection of the pedicle and the vertebral body is the critical junction, which is this. If the needle is not medial to the medial wall, if this is not crossed to the medial wall, then you're safe. And it is a safe trajectory. If it crosses that, then you're in trouble. Especially in dorsal spine, you should be very careful when you're doing this. And so this is the medial edge that you should be very careful about once you're 2 centimeters inside. So then a guide wire, excuse me, is advanced through the needle, and the needle is then removed, and then you have got live fluoro. So you pay particular attention to the localization of the guide wire. It can be very dangerous if you advance the guide wire not seeing what's in front, because there are big red vessels right in front of it, and you can cause serious problems. Anytime you see a wire going in front, you have to pull it back straight away. The wires are generally blunt these days, and sharp wires are not in the set anymore, but I think you have to be very careful when you're advancing this. So same thing as we talked about. So you put in your K-wire, Jamshidi needle, and you put your K-wire in there, but you have to keep an eye on the K-wire that your wires are not holding. So all these have to be tied up, stapled at the back. And as you see, when you're using fluoro, use some kind of instrument to ensure that you're not putting your hand in between. The fascia and the muscle is then dilated to the screw head diameter. And there are 3 dilator guides over the wire. In some sets there are 4, in some sets there are 3. And when you've got to remove one dilator on top of the other, then what you do is you tap is performed and check lateral to avoid further advancement. The tap has a marking on the shaft. So when you're tapping this, you can see the marking how far down you can go. And at the same time, you need to be looking at the fluoro to make sure that your wire hasn't crossed interiorly. Your assistant has to be holding the wire on the top to ensure that obviously the safety of the wire not going anteriorly is important for us. The screw assembly is then advanced over the guide wire to the appropriate depth. And this is the assembly that we use. And the guide wire should be removed once the screw shaft is through the pedicle. So once you're in through the pedicle, the screw has to go, because you don't want to be causing a kinking of the screw or problem if you want to be tilting in any way. And you can go as far anteriorly possible when the head fits the facet or the TP. So the tapping is again like that, and you need to be careful that you don't want to be kinking. You need to be going straight up onto the wire, not making an angle. Otherwise, you're going to cause problems to the wire itself, and it can kink and run into serious trouble. You have to plan your screws beforehand. For example, if you want to be correcting the deformity here, so your angles that are coming here, you should be able to correct it by bringing it up and down and using your rod accordingly. So you have to plan it where you're going to enter from. Would you be entering from here or here, depending on what kind of angulation you want to be giving to this particular construct. And then place the contralateral screw over the wire. So you go sequentially. So you go on one side. First, you've got the Jamshidi needle, the wires, the tap, then on top of it, the screws. And once you've had that, then to the opposite side as well. And then there are different types of instrument gauge that we have available, of different type of rod placement that you can apply depending on how many level you're doing. For example, it's a single level, and what you do is you slide on top of it and just turn it around and be able to release the rod down. And on top of it, you need to put the hardware on both sides. And you can feel it from the top with the help of their special feeders available. And the process is repeated for the second time on the same side of the patient, and both assemblies should fairly easily be moved after insertion. If you're not able to move them properly, then you're missing out something and you have to go back and check. Always look from the top, that you should be able to see the rod from the top. Remember, the screw head determines the trajectory. So the way you're going to be coming in, your starting point, the depth of the pedicle screw, where exactly it's going, and how is it going into the rod insertion easily or not, is very important for us. And all this has to be seen. So there are different types of constructs. For example, the sextant, which works exactly as good as any other system. So you can use various methods of putting it in, and all of them work the same way, and the results are pretty reasonable. The important thing to understand is that if you're going to be bringing it from the top, it should be okay, but sometimes from the bottom it would be difficult. So you have to plan the surgery beforehand to know which side you're going to be bringing in from and how many level you're doing. So for example, this particular video, so it basically shows that we use the tap, the wire, and the screw, and the rod that goes on top of it after just measurements of how many level you're going to be doing in, or what exactly you're going to be doing. So basically, the screw and screw extension assemblies are percutaneously inserted into the pedicle, and this is very simple. And the alignment of the screw extension again is in the same way. Holder assembly are both according to the guide of the rod placement that we do. And I think it makes it very, very simple with these new types of instrumentation that are available. Now we're able to even do 4 or 5 level at one time with the help of these new rod assemblies that are available at the moment. Then a rod holder captures the rod. We tighten it up just like we saw earlier. The important thing is you don't want to be that the wire is going all the way anteriorly and causing problems. This is a patient somewhere from another one in which we have tried to go at a wrong angle and cause the wire to be stuck there. And now it's a problem because you can't get that back. So then it was fixed as it is. So in summary, there is adequate imaging from fluoro or image guidance is essential. Without a plan, I think it's very difficult to do this. Cannulate the pedicle, place guide wires, advance the screws, attach the rod. Multiple vendors have the systems. Screw placement is generally the same. Main difference is in the system for rod placement and attachment, and they all work the same way, whatever you used to. There's no clear advantage of one system or the other. It's surgeon's choice. And you can try multiple vendors and see what works for you, and that is the way to do it. But the important thing is try not to have too much of radiation when you're doing this. So thank you very much. It's a pleasure to be here.
Thank you, Salman. Very nice talk. We have some questions. Which cases, trauma or degenerative, are suitable for percutaneous screw fixation? And how many levels can be fixed with this technique in one session?
Okay, obviously trauma and degenerative both are suitable for percutaneous pedicle screws. For percutaneous pedicle screws, obviously it's if somebody's got a neurology and they've got deficits, then only percutaneous pedicle screws won't sort the problem out unless you're able to do ligamentexis and reduce that. So in that particular case, you need to decompress in that particular level. Whereas with degenerative, again, if you want to be doing, for example, a fusion of some kind, for example, transfemoral lumbar interbody fusion, so you can do one side pedicle screws, the other side you put in screws and put in cage from that side. So it depends on various things. You can use it for all the type of pathology that we see. Also in multi-trauma patient, now it's become a routine that you want that patient to be up and about as soon as possible. They have multiple injuries. So what you do is you bang in the screws so that they can be mobilized as soon as possible so that you don't run into trouble. There are some new sets in which you can go up to 6 level fusions at one time. I haven't used them. I'm not sure, Mehmet, have you had experience with those? The 6 level, okay.
No.
So, I've seen videos and they work pretty reasonable. But I think it is going to be very difficult. Some of our friends in US are routinely using it and they say it works very well for them. The question is this method superior versus open technique? Obviously, as I said, if you need to decompress, then obviously it's not superior. But if you can do short surgery, because this is quick surgery, there are minimal risk involved in a patient who's got multi-trauma, who's recently had injury, then it's much easier with this. Compression and decompression can be achieved. There are now newer systems coming out. Now it's getting easier and easier. On top of it, you can use your table itself to bend and open or close to be able to compress or distract besides the routine distraction compression devices that we already have. Yes, there are some people who are using vertebroplasties with this. I'm not sure if that is a valid option because all the big studies or all the studies have not shown any benefit of vertebroplasty along with minimally invasive screw fixation. It's only used when you've got severe osteoporosis and you're trying to ensure that adjacent level problem does not happen. Then there is if screw holding system accidentally loosened from inserted screw. Obviously, unfortunately, if that happens, then you have to revise that particular level. There are as now new revision screw sets available that you can still do it, but only 1 or 2 companies have it at the moment. But there are all the companies are now trying to make those revision sets as well. So I think it's getting better and better.
Yeah, very nice. Yeah, actually, there are surgeons doing some deformities, even deformities, with this technique, but they also admit that it's not very easy. Actually, probably Professor Fessler is with us now. He can answer it after his talk. But minimally invasive osteotomies is not feasible, probably. What do you think about that?
I agree, but having said that, and I've seen some videos of some amazing work done by some of our friends, and I think it's possible that slowly and gradually, because with intraoperative CT and with the help of O-arm, people are able to do minimally invasive osteotomies, giving the same results as open surgery. So I think the future is there. There is no doubt that's going to happen, and I think in 2 years' time, yes, we will be doing all these minimally invasive with intraoperative O-arm or CT.
I would like to get the opinion of Dr. Hyung-Sung Kim. Kim, you are also doing full endoscopic cage insertions or fusion surgeries.
Yes, I'm doing.
What do you think
yes.
about that? Is it possible to make an osteotomy with endoscopic techniques?
Osteotomy for vertebral body, you mentioned that?
Yeah, osteotomy is, yeah, there are different types of osteotomies. Pedicle subtraction osteotomy, let's say.
Yes, it can possible. I also have some pedicle subtraction osteotomy on cases, but and also in Korea, there have some instrument development, some differently. We have some osteotomy chisel, and also my technique is some different drilling to around the bone structures and pedicle and vertebral body, and the partial osteotomy is possible, but it needs some development for surgical techniques for deformity cases, and still, I have some small cases of deformity cases of some scoliosis and kyphosis but maybe in the future, the endoscope fusion have a more good tips to correction of the focal scoliosis. Because of that, it needs some development of osteotome and some destruction of the segmental instability is very important point in endoscope development in the future.
Yeah,
I'm already have some of cases.
Okay, good. Thank you. Dr. Rezail, do you have any questions? You have any questions to?
No, sir.
No, okay.